Hello, my name is Nicole Amana. I'm a CLL specialist at Columbia University Medical Center here in New York, and I have the privilege of being with Dr. Clare Sun at the NIH, and she's going to talk about one of the many CLL, this is her presentation, but there were many abstracts, as you know, as many of you have probably read and seen on the CLL Society Forum, many presentations regarding CLL at the annual ASH meeting that was held in December 2022. So we're going to talk about one that I know is a very big interest to many of you patients with CLL, and that's regarding boosters and COVID boosters and vaccinations and how well patients are doing with receiving their vaccinations because of their CLL. So this was the booster and BTK interruption improved response to SARS-CoV vaccine in patients with CLL. Dr. Sun, can you tell us a little bit about this abstract that you presented at the ASH meeting?
Yeah, thank you, Dr. Lamana, for having me today. So our group has had a longstanding interest in vaccines in the CLL population. And since the pandemic, many reports have shown that CLL patients have poor responses to vaccines, especially the COVID vaccines, compared to the general population. So we wanted to investigate our center's experience because we have many patients on targeted therapies, and we wondered whether there was a difference in terms of patients on different types of therapy, as well as what strategies perhaps we could explore to boost the vaccine responses in our patients. So what this abstract looked at was all patients who were treated at the NIH during this pandemic period. And we focused on our patients who were on a BTK inhibitor. So we had patients on ibrutinib as well as acalabrutinib. And then we measured their anti-spike antibody titers following initially the primary series. And when we started the study, the primary series was defined as 2 doses. We know that definition has since changed to 3 doses, but as part of this study, we defined it as the first 2 doses. And then we also looked at the titers again after the booster or the 3rd dose. And in addition to looking at the antibodies, we also wanted to look at the T cell response. We think that T cells are also important in terms of mitigating the complications of the infection or controlling the infection itself. So we did this through sequencing of the T cell receptors on the T cells, and we're trying to look for what we think are COVID specific T cells. And that's a test that's FDA authorized to look at COVID infections. So the caveat here is we're actually looking at responses to vaccines rather than the immune response to infections. So altogether, we assessed 108 patients at our center, and we found 86 patients who met our criteria, and meaning we excluded some because they were receiving IVIG. That would interfere with our interpretation of antibodies. We excluded patients who were previously infected with COVID. That could also interfere with our interpretation of their vaccine response because they likely already have anti-spike antibodies as a result of the infection. And so among the 86 patients that we looked at, 68 of them were on treatment with either a BTKI, so ibrutinib or acalabrutinib or venetoclax. So we had 14 patients on venetoclax as well. And then we had a small group of 18 patients who were untreated that we wanted to see whether between these 3 groups of patients, whether we could identify any differences in terms of their antibody response. And we did. And so what we found was that patients who were treatment naive tended to have higher antibody titers compared to patients who were on BTKI or venetoclax. But what was interesting also was that most patients who were previously reported to have antibody responses on venetoclax in other studies had also received an anti-CD20 monoclonal antibody. But we tried to focus on the venetoclax patients who had received the monoclonal antibodies at least a year out. So we're really trying to look at that effect of venetoclax on the vaccine response rather than having that rituximab or obinutuzumab kind of confuse the data interpretation. So we found that even in patients who were just on venetoclax alone, those patients also seem to have inferior responses to the COVID vaccine as well. And then the next thing that we looked at were the T cell responses. So besides the antibodies, that's the other arm of the adaptive immune response. And we saw that about in 29 patients, about 60% of those patients had a detectable T cell response. And that wasn't always concordant with the antibody response, meaning that patients who had an absent antibody response, some of those were also able to mount a T cell response. And then we asked, whether the T cell response after the primary series could predict the response to booster, thinking that maybe T cells also participated in antibody formation, and maybe having a T cell response initially could help promote an antibody response to boosters. But we actually saw that these were kind of disconnected. So both patients with or without T cell responses were able to increase their antibody titers after their booster. So given what we saw with the poor responses in the treatment group, we thought about perhaps ways to improve the vaccine responses with the booster. And so because most of our patients were on BTK inhibitors at our center, we tried to test the strategy of interrupting the BTKI around the time of the booster. So what we did was we advised patients to hold a week before the booster dose and 2 weeks after their boost, up until 2 weeks after that dose. And then after that, we would measure the antibody, just as we had done for the primary series. And then we had a control group of patients who continued their BTK inhibitor during that booster vaccine. And what we saw was that in the patients who interrupted their BTK inhibitor, the antibody titers after the booster was higher than the patients who continued their BTK inhibitor. And it was quite a bit higher. The median was around 7,000 in those patients who interrupted their BTK inhibitor, and compared to 1,200 in those who continue. So it's small numbers, and we didn't do it in a randomized fashion. So there are these caveats to interpreting the data, but maybe it gives us the first hint that holding BTKI should be tested at least as a strategy to improve responses in this group of patients. Of course, patients have to have stable disease control before we pursue any of this, because there is a risk of tumor flare in patients if we just kind of, blindly held BTK inhibitor for everyone. So those are the main findings from our study, confirming, poor responses in patients who are in active treatment, that T cell responses were detectable even in patients without antibody responses, and that they were disconnected in CLL patients. And then finally, that holding BTK inhibitor could improve antibody titers following vaccines.
So this is, it sounds like extremely exciting work, and obviously we need more to be done in this area for sure, with folks like yourself, and hopefully that will continue. I would say you for now, we would not recommend patients to hold their BTK inhibitor, their therapy. Talk to your provider. It sounds like there's more work to be done, because this was done, the folks that held it, as I take it, was a small number of patients, correct?
Yes, there were only 12 patients who held it compared to 30 or so who continued. So definitely not something that we're saying should be applied to standard of care at this moment. We are trying to investigate it in a follow-up study where we randomize patients to interruptions versus continuous to hopefully more rigorously test the question.
Yeah, understood, right? And it also depends on where patients are in their therapy. As Dr. Sun noted, there's some patients that probably we may not want to be off therapy because maybe they've had multiple treatments and there's a risk of flare of their disease if you hold the BTK inhibitor for a prolonged period of time. So I think it depends, but I'm so grateful that you're doing this work. I'm sure the patients are grateful as well. And of course, then the question is, you noted the improvement in the initial antibody response over patients who continued their therapy. The other caveat, or I guess with longer follow-up or more studies that you plan on doing, is the rate of decline of their antibody response. How long does the response duration? Is there a difference between the two groups or not? And ultimately, how does that impact their clinical outcome in patients who may get COVID, regardless, whether they held their therapy or not? And so I take it that we need a lot more follow-up, correct?
Yes, completely agree. Yeah, the rate of decline is something that we're actively investigating to try to inform like the period, how often they should be getting boosters, because it seems like it's, the formulations are changing as well as we speak. And there's still, now that Evusheld is off the market, patients are becoming more reliant on vaccines again in terms of, humoral kind of antibody protection. So all those are really good points, Dr. Lamanna, in terms of, there's still a lot of unknowns that remain unanswered.
Great. Well, thank you so much for presenting this work at the ASH meeting and for continuing your work in this endeavor. Thank you.
Thank you.
Okay.